Good morning. Today I'm going to talk to you about community health planning. After today, you will be able to understand the basics of public health and the public health system, define social determinants of health, understand the importance of a community health assessment and its major components, understand stakeholder engagement, understand different data sources and types needed to complete a community health assessment, and understand the importance of a community health improvement plan and its major components. In order to understand the importance of a community health assessment, we have to take a step back and really define what is public health. The Institutes of Medicine have defined public health as the activities that ensure conditions in which people can be healthy. These activities include community-wide efforts to identify, prevent, and combat threats to the health of the public. In a broad sense, public health does some of the following things. One is to prevent epidemics and the spread of disease, protect against environmental hazards, prevent injury, promote and support healthy behaviors, preparing for, responding to, and recovering from public health emergencies, and assuring the quality and accessibility of health services. People think about the public health system, they think about public health agencies, whether they be local, state, or federal. But when we talk about the public health system, it incorporates many more groups as demonstrated on this diagram, from schools, emergency response, hospitals, doctors, law enforcement, tribal health, corrections, lab, home health, nursing homes, nonprofits, civic groups, fire, mental health, faith-based institutions. Because if we think about the ability to create conditions in which people can be healthy, that takes all of these organizations to work together in a coordinated effort to be able to have that sort of impact. It's not just the health department doing this work, but working with all of these partners. Other important considerations when you think about creating conditions in which people can be healthy are social determinants of health. Now, what does that mean? When we talk about social determinants of health, we're talking about the conditions in the environment where people are born, live, learn, work, play, worship, and age that affects a wide range of health, functioning, and quality of life outcomes and risks. These affect everyone in one way or another, and they also contribute to health disparities and inequalities. First, we're going to talk about community health assessments. So what do we do with all the information when we think about all the work that public health does with all the different sectors of the community, as well as those social determinants of health that affect everyone everywhere across the country? Well, in order to really understand what's going on in our communities and how different factors affect health, we need to do a community health assessment, or a CHA. So what is that? It's a process that engages with community members and the local public health system partners to systematically collect and analyze qualitative and quantitative health-related data from a variety of sources within the specific community. But really, in more plain language, is taking the steps to understand the health status and health risks in a community using data from multiple sources. So why should a health department complete a community health assessment? There's multiple reasons, and we'll talk about a couple of them right now. The first reason is it really helps understand the health problems to inform community-wide decision making. It also allows the development and implementation of a community health improvement plan with stakeholders implementing different portions to drive the needle to improve health and health outcomes for residents of an area. And it's also an opportunity to build or strengthen relationships with community and state partners. So really looking at that whole public health system and all those partners and figuring out ways to actually work together to improve health. A community health assessment has many components, which we'll go into, but those components include participation of a diverse group of community stakeholders, development of a shared goal or vision, data from a variety of sources, including primary and secondary data, description of the demographics of the population, description of health issues and any population groups with specific health issues, a description of the assets or resources to address health issues, and distribution of those results to the stakeholders and the public. So stakeholders are persons, groups, or entities who might be affected by or influenced by an effort. These might include those interested for academic, political, or philosophical reasons, and the interest depends on how they affect or are affected by the effort. It is important that we identify and analyze stakeholders and their interests in the community health assessment process. We need to ensure that we have good perspectives from all sectors and elements of the community, which will help gain buy-in and support for our effort. It gets more ideas on the table. It can strengthen the position if there's any opposition. It creates bridging social capital. It increases the chances of success for the effort. Identifying stakeholders and making sure the correct people are there is kind of like planning your party. Who will make the best guests? What should they bring? Who do we have to invite? What's happening during our party? And what do we want everyone to say after our party? So when thinking about what stakeholders to ensure are being represented when you're doing your community health planning process, we need to think of that broad cross-sectional participation. This allows membership is representative of the perceptions, needs, and interests of the entire jurisdiction. We need to think about any other criteria that we might need them to meet. So consider their expertise, maybe access to assets and resources within the community, and then also who plays a role in the local public health system, thinking back to the bubble diagram that was shown on an earlier slide. These are those individuals that have a hand in providing public health services. We need to make sure we have diversity and inclusiveness so all sectors of our community are represented, and then also a need for long-term availability and interest in the planning process. Now I'm going to pause for a minute and thinking about your own jurisdiction when you're getting ready to either complete a community health assessment for the first time or update your current one. Really think about what stakeholders in your jurisdiction should be participating in your community health planning. As you're thinking about the reflection question, think about the public health system and remember that it doesn't just include our traditional public health agencies, whether they be state or local, but includes a broad sector of our communities, because these partners all need to be involved if we're really going to create conditions in which people can be healthy. And once you have a list of stakeholders that you think should be included, the next step is to really identify what those stakeholders' interests are in the process and the plan. Like, what do they care about? Identify planning teams' desired input from each of these stakeholders, which will help inform that planning process. So what information, knowledge, or data can they offer, or what important or diverse perspectives are they going to bring to the table? Then we need to identify how we're going to involve each of these stakeholders in the planning process. Some need to be actively involved in the planning process, and others, maybe they just need to be more informed and being able to provide input at certain time points. So in summary, community health assessments are important planning processes to engage stakeholders to understand the health of the population. And it is important to make sure a broad sector of stakeholders are included in the planning process to really be able to truly understand the health of the jurisdiction. Now that you have your stakeholders together, the next important part of doing a community health assessment is to get the necessary data. There are two broad categories of data that must be included in a community health assessment. The first is primary data. That is the data that you collect. It can be quantitative or qualitative. It is most commonly collected through the use of surveys, focus groups, key informant interviews, or town hall forums. The other type of data is secondary data, and this just means that the data is collected by somebody else. It can be quantitative or qualitative. Let's talk about the difference between quantitative and qualitative data. Quantitative data is the quote-unquote hard data. This includes rates, percentages, counts, averages, etc. Usually this type of data has statistical properties. where sometimes we can allow generalizing it to a larger population. A couple very quick examples are, say, 25% of adults smoke, or 3 cases of melanoma per 100,000 people in County X. Qualitative data are sometimes what people refer to as the quote-unquote soft data. These can be those comments on a survey, open-ended questions, focus group discussions. These are ones that usually cannot be generalized to a larger population because they really are a lot of times people's knowledge, attitudes, or beliefs about a certain subject. So an example, a healthy community to me means good jobs and schools. Or if our community had more parks and walking paths, I would exercise more. So the qualitative data a lot of time tells the story behind some of the more quantitative data. We briefly touched on this, but I'm going in a little bit deeper about what secondary data is. As I said earlier, this is data collected by someone else. It can be quantitative or qualitative. It can allow understanding of a health concern and help us identify gaps in data that we don't understand about our community. So what are some examples? So there are good examples that are collected at the state level and the national level. For instance, the behavioral risk factor surveillance system, or the youth behavioral risk factor surveillance system, birth death records, hospital discharge data, emergency department visits. There's a lot of these large data sets or surveillance systems that are available that can tell us a lot about our jurisdictions across the state. And the link in the slides can take you to where a lot of these data sets are, and you can look up the information for where you live. So once we review the secondary data about our jurisdiction, we have a pretty good understanding of what is already known about our population and our health concerns. But a lot of times there's still gaps exist, or maybe there's an area that we were surprised to see had maybe such a high rate of something, and we want to dig deeper to understand the why. This is where the primary data comes in. Along with your stakeholders, you're going to review that secondary data and say, okay, here's where our gaps are, or here's where we need to know more information. And we are going to go out and collect data to help us fill in that gaps and understand a more complete picture of the health of our residents. So this can also be quantitative or qualitative. Like I say, it's used to complement and fill in the gaps of that secondary data. And this is really where it's important to make sure your stakeholders are engaged in the process. And some examples of ways to collect the primary data include surveys, focus groups, key informant interviews, and town hall forums. One way people collect primary data is through surveys. There's various data collection options. You can do a telephone, in-person, online, mail-out survey. They can be qualitative or quantitative. But like any time we're going to collect primary data, we need to determine what we are actually going to collect. Are we just looking for gaps in the secondary data to really try to fill those in? Are we using this to understand maybe our residents' perceptions around a certain issue? So in order to make sure we get the correct data collected, we need to develop a plan. What are objectives? What are the approaches? What kind of survey are we going to do? Are we going to do a random versus a convenient sample? How many resources are we going to need? Are the resources for people doing phone calls, going door to door, etc.? And what stakeholders, of course, need to be involved when we're trying to determine what questions we're going to ask. And the other thing we need to think about is what technical assistance might we need when we're going through this process. And some examples are, do we need help developing questions? So we make sure we have unbiased questions and are using questions that have been standardized and validated. And once we get all those surveys back, what are we going to do with it? Do we need help analyzing that so we can take that data that we collected and actually turn it into information to be able to be useful to drive where we're going to put our resources to address health concerns? If we decide to do telephone interviews, there's quite a few pros with doing those. You get a higher response rate than with written because it's harder to hang up on somebody than to throw a survey in the mail. You have a greater control over your sampling to make sure that you actually get a random sample. This is consistent with several national studies out there, national surveys that are done this way. And also because somebody's on the phone with the person doing the questions, It allows for clarification if there's complicated skip patterns or clarifications of the question being asked. And a lot of times it works great for our senior population. However, it can be very costly. It takes a lot of resources to do a telephone interview. And the other thing to think about, we don't want to miss any specific subpopulations. And if we're only using telephone interviews, there are cell phone only households. There can be language barriers. There's undocumented people that we may not be able to reach. A lot of times people have prepaid cell phones. There's no way to get those cell phone numbers. And sometimes low income and homeless are not reached this way. So there can be gaps in our knowledge. So if we're trying to make sure we understand the health needs in some of these subpopulations, then this might not be the best way to go collect that data. Written surveys can be used as well, and these are a better way to reach houses without landlines. They are cheaper than doing a telephone survey. When somebody has a written survey, they're able to complete the survey on their own time. Sometimes that helps. And you can use connections in the community to distribute these surveys, so it helps reach some of those populations that might be harder to reach. However, postage can be costly. You do not have as much control over sampling because we can do a random sample and mail those out, but return and response rates can be very low. There also can be potential problems with skip patterns, people not following them or doing them incorrectly, or also if there's a question about what is meant by that survey question, people don't have somebody they can ask right then and there. And the other thing is you can also miss important populations doing data collection this way as well, people who are undocumented or have a language barrier. Online surveys are probably the least expensive method. There's a lot of online software available, with SurveyMonkey being one. Anytime something is more techy, we reach the younger generation more effectively. Most of these online programs have reports that are easy to generate, as well as data analysis, and skip patterns are easy to install. However, you do not have as much control over sampling because the survey link can be shared, so a lot of times it's hard to get a random sample. So it can take a long time to get required numbers. You can, and some of these, put control of the number of times a person fills out a survey. Sometimes you cannot, so some people could potentially submit the survey more than once. Usually we make sure there are more closed-ended questions, less open-ended questions. And you, once again, can miss important populations, those with no internet access, low income, homeless, language barrier as well. Another option for primary data collection is face-to-face interviews. These have higher response rates, allow for clarification of responses during the data collection, allows you to have control of the sampling, and can be very effective for hard to reach populations. However, these do require a lot of person power in order to be able to conduct. They can be very time consuming. And if you don't have any volunteers, it can be costly to hire enough people to be able to do the data collection. And then if you do use volunteers, training is paramount to make sure that there's consistency in how the data is collected. So once we figure out what type of data collection we're going to do, we need to figure out what type of sampling methodology we are going to use. So we're going to talk about the two different buckets of sampling and talking about pros and cons of each of those. So one is a convenient sample, and this just means that you collect data or interview whoever is most accessible. They could be people at the county fair, people that come into the library. It's just whoever happens to be at that position who's willing to be interviewed. The caveat with these is that the results are not generalizable to the whole population. So really what this means is the results don't represent the whole area when you're looking at it. They really are just the opinions of the people surveyed. In order, if we really want to be able to talk about the whole population of our jurisdiction, then it's best to do a random sample. And so what that means is that a sample population, or the people interviewed, are selected to represent the target population, or our whole community or our whole jurisdiction. So really what this means is a random sample is defined as being or related to a set or an element of a set of whose elements has equal probability of occurrence. So it just means that we're taking a sample, a small group of people that we're selecting that will be representative of the larger population as a whole. And there are three basic types of random sampling that can occur. There's a simple random sample, where each individual is chosen entirely by chance and each member of the population has an equal chance of being included. So this is used most commonly when the population is similar or homogeneous. And this can be done with a random number generator. If you have a list of, maybe you're using a list of registered voters in your community, and you can use a random number generator in Excel and get your simple random sample. A stratified random sample means samples are taken from each subgroup of a population so that each segment of the population will be represented in the sample. So this is used when a population is dissimilar or more heterogeneous. So it's kind of like if you think about your community and maybe you have, it's not a bell curve of age distribution. You have a lot of seniors and a lot of youth, or maybe we have a lot of migrant workers, or whatever that might be. We want to make sure that we hear voices from all of the different populations within our community. Then this is a good way to do that. And then there's the cluster sampling. This is when a population is divided into distinct groups or clusters, and this is usually census blocks. And then we take a sample of those clusters or census blocks, and then another sample of people within those sample blocks or clusters are chosen. This can also allow extrapolation to the whole population of the defined area, and population needs or health status can be estimated from the sample as well. Another option for getting some primary data are the use of focus groups. The things to remember with focus groups is this is qualitative data only, and it really does require a very strong objective moderator when bringing those people together in the focus group. A lot of times we recommend only 5 open-ended questions or even less than that, because it's a way to get people's opinions as they're asking or being asked these questions. These are not generalizable to the whole population. You are really just getting this small group of individuals kind of knowledge, attitudes, beliefs about a certain topic. And you can use focus groups when you want to make sure you get specific subpopulations, or maybe there's specific professional groups, or maybe it's just the general public. You feel you're missing some of that. So these are a way to do that. Sometimes people use focus groups as well for a community health assessment within each of the communities within a county. So they're making sure they get those voices. And this can be a very good way to get some of those knowledge, attitudes, beliefs around health. But just remember that this is not generalizable. This is just a way to augment some of the other data that you have to kind of do some of that storytelling. And just some other tips about focus groups. A lot of times financial incentives are offered. Those can be like chamber bucks, or maybe you have dinner or something like that in order to get people to show up. You try to recruit 12 and you hope 10 show up. Focus groups are recommended to last between 90 to 120 minutes. You want to make sure you have a convenient location, and that whoever is doing the focus groups has a moderator guide to follow, so they make sure they stay on track. It's good to offer refreshments, and it does take at least a couple weeks to get the recruitment. And with those participants, you want to make sure that you can ensure their anonymity during all of this. They don't think that what they say is going to end up at the local coffee shop. If audio taping, you need to let the participants know up front. Sometimes it's easier to do the taping, so then those can go back and be transcribed. But like with any of those things, when somebody's recorded, the participants need to know before they start participating in that discussion. When you go ahead and report out results from focus groups, you want to describe the demographics of the groups, and you pull out key themes from the questions, and then you can use quotes to emphasize important themes or things that people said that were particularly impactful. And like I say, this is a really good way to augment some of the secondary data and some of the more quantitative data. Another option to augment either survey data or your secondary data is key informant interviews. And so what these are is a way to garner feedback from a common target in a community. And common targets that people think about are people that are involved in the community in a way that involves health. So for instance, elected officials, health department, your hospital clinic staff, schools, faith-based organizations, business, not-for-profits. It's just kind of thinking through what are some groups that we would like to get some more information from. And these are usually a mix of open-ended and closed-ended questions. But once again, the caveat with these is they're not generalizable to the whole population. You're really looking specifically to answer some questions that are targeted at these group of individuals and the role that they play within the community. A lot of times they're done via telephone because it's a way to clarify. It's a little bit easier than going face-to-face. Although some people choose to use online surveys and allow people to respond at their convenience. So it just depends on how many individuals you have helping during this phase of data collection with your CHA, whether it makes more sense to do something online or something more with the telephone or in person. And the same thing here, when you're going to report this out for your community health assessment, you want to pull out key themes. And once again, you can use quotations to emphasize important themes or important things that people say that will really help paint the picture of health and the community and really those knowledge, attitudes, beliefs. So here's some key points to think about with primary data collection. The point of this is to really fill in the gaps once again for the secondary data and that really quantitative data that's known, because you want to make sure your entire community/jurisdiction is represented. And a lot of times people choose to use more than one type of primary data collection. They might do a survey and then say, ooh, we need to do some focus groups with certain subpopulations, or maybe we want some key informant interviews because we really want to look at some of the policies or how people feel around some of the things that are impacting our community. And this is where it's really important to make sure you have those partners and stakeholders at the table to determine what is the best way or ways to collect that data to get a full understanding of health in your jurisdiction. And once again, these do take time. Primary data collection takes time, and you need to have a plan laid out so you know what you're trying to answer and what makes sense in order to get to that endpoint. So you actually have data that is usable in order to be able to really understand health and be able to make a plan with your stakeholders and partners to address those health concerns. Let's pause a minute. When thinking about all the different options for collecting primary data, what method or methods would work best in your jurisdiction to ensure a broad understanding of the health of the residents is gained? Now, I know it can seem like quite a mountain to complete a community health assessment, and a lot of people do wonder, why do we have to use multiple data sources? And just some things to keep in mind, all data has limitations. Even the data that we collect at the state level or that is collected at the federal level, all data has some sort of limitation. So by using data from multiple sources, we can overcome some of the limitations of the individual data sources. It allows us to get a more complete picture of health, including some of those social determinants of health questions that maybe are not captured in our traditional data systems. And it also really allows your community and stakeholders to be engaged, to get buy-in, and people can really feel that their voice matters in their health and that they have a say in their health and in understanding what is occurring in their community. So once you have your stakeholders together, you've reviewed your secondary data to determine where the gaps are and develop a plan for primary data collection and get that analyzed, and you have that complete picture of health and where your health concerns are. The next step is to really work with your stakeholders and community partners to understand the assets and resources that are available to enhance community well-being. And some of these examples can include local parks or recreation centers, farmers markets, public facilities, mutual aid or groups or support circles, nonprofits and not-for-profits. It's looking at all of those pieces that can be mobilized to address the health concerns that are found. So just to recap, there's a lot of data that goes into a community health assessment, primary and secondary data sources. And really the take home from this is that determining what data is needed and how to appropriately gather the data is key to actually being able to understand the health of the population. And it's just as important to have those very hard data, that quantitative data that gives us our rates and percentages, as it is to collect that primary data that gives those knowledge, attitudes, beliefs, perceptions about a community, and putting those together so there is that complete picture of health and that there is a very good understanding of what is occurring. And just an example of this is sometimes the data might tell us, ooh, we have very high rates of diabetes and that should be our primary concern. But maybe a youth just committed suicide. And when you talk to community members, they're really concerned about youth suicide prevention and mental wellness. So if we were to ignore that and just say, well, the secondary data only tells us that diabetes is a concern, we are going to miss that, and we are going to miss that engagement and being receptive and understanding what the community also perceives as important. So it's kind of looking at all of those pieces and working with stakeholders to determine where we really need to put our resources and where we need to go in order to improve the health of our residents. So now you have your community health assessment. You understand the health concerns, the health successes, and all of those pieces. Now what? We need to actually do something with those results. And that is where a community health improvement plan, or a CHIP, comes in. And in this section, we'll dive into what that means and why this is an important part of the process. So how do we address these health issues in a coordinated event with all of our community partners and stakeholders? We do this community health improvement plan with those same stakeholders that helped us work on our community health assessment. So what exactly is a community health improvement plan, or a CHIP? So the official definition is that it's an action-oriented plan outlining priority community health issues based on the community health assessment and stakeholder input, how these issues will be addressed, including strategies and measures to ultimately improve the health of the community. But really, in plain language, what that means is working together as a community to address a health issue or issues. So why do we complete a CHIP? This CHIP is also a community-based participation in improving health. The information that is gained is going to help direct health efforts. So we're going to decrease duplication. We're going to be able to do collaboration. We are going to be able to leverage resources, and we are going to be able to have a unified effort in order to address the health issue, with each of the sectors having their own role that they play. And it's a way to show the community that their concerns were heard, and showing and being able to highlight how efforts are being directed to improve those health concerns that were found. It also can be useful for grant applications to get funding to address these health issues. And then selfishly at the state level, it helps us really understand what's occurring, and will help us with our state level health planning as well. So the key components of a CHIP are participation of a diverse group of community stakeholders, just like in our community health assessment. We make sure that that community health assessment is shared with this group of stakeholders and that they understand the health concerns. Then we prioritize community health needs with measurable objectives, strategies, and performance measures with measurable time frame targets. We also look for policy changes that might be needed to accomplish these objectives. We also identify individuals and organizations that accept responsibility for implementing that part of the CHIP. We monitor our progress and share our successes, and also distribute those results to the stakeholders in public. So when we look at our community health assessment with our stakeholders, and we look at all the areas that could use some improvements around health, how do we pick 1, 2, or 3 areas to work on depending on the size of our jurisdiction? Well, we need to prioritize. And an example of prioritization criteria includes one that's based on impact, preventability/controllability, feasibility, and existing support. So when we think about where we are going to direct our health efforts, we want to make sure that we are going to have an impact, right? And is this health concern, does it have a high prevalence or incidence or severity in our community? What is a long-term impact around this? Do we have the ability to actually prevent this condition or control this condition? And is it really feasible for our community to actually work on this health concern? Are we able to actually come up with things that are going to contribute to improving this health issue? And then also, what are the existing efforts to address this issue? Do we have support that exists elsewhere within our community, or maybe within our local public health system partners, that will actually allow us to be able to do something about this? So for instance, we all know that cancer a lot of times is a big concern in a community, But cancer, as we know, all the types have different risk factors. There's genetic components. It's a very complex thing when we think about it. So for us to come in and say we are going to improve cancer rates in something that broad really doesn't fit a lot of these. Now, if we were going to come in and say we want to reduce smoking related lung cancers, well, that's more specific, and we know that we can have an impact. If people quit smoking, we know that that decreases their risk of cancer, even if they smoked prior. For every year they quit, we know that decreases some of their rates of cancer. We know that there is some ways to prevent people from smoking, as well as ways to help people who want to quit smoking. We know that there are ways, programs to implement around tobacco cessation. We know that there's existing support. So that's kind of a way to think through that as an example. So once we figured out what health concern or health issues that we are going to include in our health improvement plan, we really need to figure out what are some measurable objectives, what are some strategies we're going to do to try to improve this health concern, how are we going to measure our success with this, and what do we hope to accomplish within a year, 2 years, 3 years. We also need to identify any policy changes. So for instance, I'm going to use the smoking example. Maybe we really do want to address tobacco use and vaping use among our population. So we can say that we want to decrease smoking rates among residents of County X by 5% in the next 3 years, something like that. Policy changes. In Montana currently, the Clean Indoor Air Act does not include vaping and vaping products. So something that could be done at the local level with the way our system is set up is that vaping products could be added through the Board of Health and the governing body as it passes a resolution and added to the Clean Indoor Air Act for that jurisdiction. You don't have to wait on the state. And then also when we talk about identify organizations for this responsibility, we know that our Board of Health and governing authority would be involved, as well as businesses where, whether it be bars, restaurants, etc. So those are some ones that would be involved in this. And then we know as far as measurable outcomes, we can create an outcome that we then can measure our success moving forward. So that's just kind of a quick example of how this would occur. So one thing that can be somewhat tricky when you think about a health improvement plan is, I just want to go over a couple of the definitions of things that are usually in there. So a goal is really this broad or general statement or desired change or end state. Maybe it's something like no residents of County X smoke. The objective, this is really where we go into those SMARTY objectives. They are these measurable statement of specific desired change or end state. So they are strategic, measurable, ambitious, realistic, time-bound, inclusive, and equitable. So it's coming up with that. Then the strategy is how we are going to change that objective, right? How are we going to achieve that objective? And then the tactics are very specific, programmatic policy, other actions that's going to take that strategy and make it play out in real life. And then performance indicators really measure that, how well those strategies, tactics are working or performing. And it allows us to monitor our progress. So if things aren't maybe working as well as we'd like, we can figure out what we need to change in order to make an impact. So here's an example. Maybe our goal is to reduce the incidence of pediatric asthma and its effect on children's lives. That's our broad goal. So our objective is to reduce hospital emergency department visits for pediatric asthma by 20% within 3 years. And we know that we have data sources to measure this, the hospital emergency discharge data system. So what are some strategies in order to do this? So assess and reduce environmental triggers at home and in the school, because we know that with asthma, a lot of those environmental triggers can cause those asthmatic attacks. So working with parents that have kids that are asthmatic, as well as in schools, making sure that there are not those environmental triggers, or at least trying to reduce those. So what's a tactic? How are we going to do that? We're going to look for grant funding and partners to implement those asthma trigger assessment and education of greater than or equal to 80% of the home children with asthma. And our performance indicators, as we look through this over the next 3 years, are going to be the percentage of homes reached by the asthma trigger assessment. So here's an example of how that would play out in your health improvement plan. So the final steps are then to look for policy changes needed to accomplish those objectives, identify those individuals and organizations that accept responsibility for implementing. We need to monitor our progress, whether that be quarterly, and then we also need to be able to distribute those results to the stakeholders and public and show what we're doing and how we're doing it and how successful we are in our process of moving the needle on those health concerns. So let's take a minute to pause and think about this. How will you ensure the Community Health Improvement Plan has broad participation in the process and in implementation? So how are our CHAWs and CHIPs used? Really, the primary goal of these two planning documents is really to inform a community or jurisdiction of where to put our resources and collaborative efforts for improving the health of the community. It allows an understanding of the broad health of a jurisdiction, where are some of the issues that we might have within our jurisdiction, bringing partners together to mobilize them to address those health concerns, and then doing that collaborative effort and pooling of resources to actually address that health issue and hopefully move the needle. And it also allows a way for using these documents to go after grant funding. So if you do find an area that is a health concern, you want to go for grant funding, they're going to ask you these same questions. How are you, what are your objectives? What are your strategies? How are you going to address this? This is all set up that way. And then grant funding can be gone after in order to start to implement some of these tactics and strategies to actually improve the health. Also at the state level, the Montana Department of Public Health and Human Services and other statewide partners really look at both of these documents to really understand what the health concerns are across the state, what our community is working on, because it helps us understand where the health needs are, helps us when we look at federal funding sources available to make sure that we are going after the right type of funding to address the health concerns that we're seeing across the state. So let's pause again for a moment and think about how will your department use the results of the CHAW and CHIP to improve the health of your jurisdiction. So here is a list of both national and statewide organizations that can be good resources in your process of working on your CHAW and CHIP. Just want to thank you for listening to this, and if you have any questions, please don't hesitate to reach out. We have a lot of resources and support both in funding and technical assistance at the state. Thank you and have a good day.